my name is Amber Goana and I would like to welcome you to my Med Talk. This is going to be some of the things I pulled from the CPJE California law exam, and as you can see, it's going to be basically like a little Naplex, and so each video is just going to go over each section that I kind of pulled little things from, and I hope you like it. So for this section, we're going to be going over medications that have FDA approval for the use of asthma and or COPD. First up, we got short-acting beta-2 agonists. They target the beta-2 receptors that's going to relax bronchial smooth muscles and cause bronchodilation. These are more like rescue inhalers. There's albuterol, Ventolin or ProAir is another name. It's 1 to 2 puffs every 4 to 6 hours as needed. Each inhaler has about 200 puffs in the container. We have levobuterol, Sopanex. It's 1 to 2 puffs every 4 to 6 hours as needed, just like albuterol. It does have an R isomer, and it's actually more potent than R isomer. We got Combivent, which is made up of ipratropium and albuterol. So the albuterol is going to be that short-acting component. Ipratropium is a short-acting muscarinic antagonist. It's 1 puff 4 times a day as needed, or it could be scheduled. But here lately, I've been seeing prescribers doing it more as needed. The max is 6 puffs a day. General precautions with these short-acting beta-2 agonists. You want to caution use in cardiovascular disorders, glaucoma, hyperthyroidism, diabetes, ketoacidosis. It should only be used as a rescue inhaler, not really for like a maintenance. It's really for rescue. Side effects include tachycardia, tremor, palpitation, hyperglycemia, and hypokalemia. So it can cause the glucose in your cells to come out, but it's going to push potassium into the cells. Some monitoring you can do with these patients. You can do a peak flow or a pulmonary lung function test. Frequent use, like how frequently they use these rescue inhalers. You want to monitor their potassium level as well as their blood sugar levels. Then we have long-acting beta-2 agonists. They also work on the beta-2 receptors and relax bronchial smooth muscle, causing that bronchodilation. One example is salmeterol, Servant. It's 1 puff twice a day. There is a discus version. It is good for 6 weeks after you open it. It is known to cause QT prolongation and muscle pain. There's Advair, which consists of salmeterol, the long-acting, and then there's a fluticasone, which is a corticosteroid component. It's 1 to 2 puffs twice a day. There's also a discus version. It's good for 1 month after you open it. For Formoterol permafrost, it's 2 times a day with a max of 40 micrograms a day. It only comes in a nebulizer formulation. So you can do 2 breathing treatments in a day with a max of 40 micrograms a day. Symbicort formoterol is the long-acting component. Budesonide is the corticosteroid component. It's made up of those 2 things. You want to do 2 puffs twice a day. It's good for 3 months after you open it. Then we have Brasivi. It consists of formoterol and glycopyrrolate. Glycopyrrolate is a anti-muscarinic component of it. It's 2 puffs twice a day. Formoterol, Brovana, is twice a day with a max of 30 micrograms a day. It also only comes in a nebulizer version, just like formoterol. So Brovana and permafrost only come in nebulizer formulations. Next we have Indacterol, Arceta. It's a capsule formulation. It's inhaled once daily. Tibron Neo inhaler consists of Indacterol, which is that long-acting component, and glycopyrrolate, that anti-muscarinic. It's also a capsule formulation that's inhaled twice a day. So Arceta and the Uteron Neo inhaler is going to be a capsule formulation. We have Odacterol, Stervidi, It's 2 puffs once a day. It's good for 3 months after you open it. There's Stilito, which is tiotropium and aldosterone. Tiotropium is a long-acting muscarinic antagonist. You got 2 puffs daily, good for 3 months after you open it, and it is known to cause dry mouth because of that anti-muscarinic properties. You got Brio, Volanterol is the long-acting component, and fluticasone is the corticosteroid. 1 puff daily is good for 6 weeks after you open it. And lastly, we have Anuro, which is imeclidine and Volanterol. Imeclidine is a long-acting muscarinic antagonist. It's going to be dosed 1 puff daily. All of these long-acting beta-2 agonists have a black box warning for asthma-related deaths when used as monotherapy. It should only be used when a patient is not adequately controlled on long-term asthma with inhaled corticosteroids. General precautions: combination with a medium dose corticosteroid shows better outcome when reducing exacerbation risk, improving lung function. The duration of action is longer than 12 hours, so it has a very, very long half-life compared to the short-acting. Some side effects include tachycardia, tremor, palpitation, hyperglycemia, and hypokalemia, just like the short-acting ones. You want to monitor the same thing: peak flow, pulmonary function test, how frequent the patient is using it, their potassium level, as well as their blood sugar level. Next, we have corticosteroids. They're going to inhibit the inflammation response that is usually seen mainly in asthma, because asthma is more of an inflammation problem. COPD is more of a structural problem. But whenever a COPD person has an exacerbation, you could see them be put on a corticosteroid for short term. We have beclomethasone, QVAR. It's 1 to 2 puffs twice daily with a max of 320 micrograms every 12 hours. You do not shake the meter dose inhaler of QVAR. Don't shake it. Budesonide, Pulmicort Flexhaler. It's 1 to 2 puffs twice a day with a max of 720 micrograms every 12 hours. There is a discus version, and this is actually the preferred corticosteroid to use in pregnancy, budesonide. There's Symbicort, which consists of budesonide and formoterol, which was that long-acting beta-2 agonist. 2 puffs twice a day. It can be used in children as young as 1 year old, and it is good for 3 months after you open it. There's fluticasone Flovent, 1 to 2 puffs twice a day. There's also a discus version of this. You have Advair, fluticasone, and salmeterol, which is a long-acting component of beta-2 agonists. 1 to 2 puffs twice a day. It does have a discus version, and it's good for 1 month after you open it. Mometazone Asthmanex, 1 to 2 puffs once daily, or it could be twice daily. There is a dried powder inhaler version, so it's going to kind of come where the patient has to have really good lung function to breathe that powder in. It's good for 6 weeks or 45 days after you open it. There's Dulera, mometazone with formoterol, so it has a beta-2 agonist in it, long-acting. It's 2 puffs twice a day. There's cyclesinide, Alvisco. It's 1 to 2 puffs twice a day. You do not want to shake the meter dose inhaler. So just like QVAR, you don't want to shake this Alvisco. There's flunisolide, Aricepan. It's 2 puffs twice a day. It actually has a built-in spacer, which is going to be good for that thrush whenever you have that little space in between the patient's mouth and the actual inhaler. Less of a chance to hit the back of the throat and actually get solely into the lungs, but you still want to make sure the patient reaches their mouth out and stuff. There's also Brio, which consists of Volanterol and fluticasone. The Volanterol is a long-acting beta-2 agonist component. It's 1 puff daily, good for 6 weeks after you open it. General precautions with all these corticosteroids: they can cause serious cardiovascular events with excessive use and adrenal suppression at high doses in patients who use it over a prolonged period of time. Spacer, again, is good to use to prevent that oral candidiasis, that thrush. Side effects include thrush, dysphonia, which is kind of like a raspy voice, headache, bone fracture risk is increased, as well as bone growth retardation at high doses. You want to monitor children's growth, pulmonary test, and bone mineral density. Next, we have leukotriene modifying agents. They're going to inhibit LT1, which affects bronchospasms, mucus secretion, microvascular permeability, and airway edema. This is mainly going to be used in asthma, not so much COPD. It's not really FDA approved for that. You have montelukast singular. It's 10 milligrams daily. You want to make sure the patient is 15 years old though when they're taking the 10 milligrams. If they're 6 to 14 years old, they could take a 5 milligram. If they're 1 to 5 years old, they can take a 4 milligram. That 4 and 5 milligram comes in chewable tablet forms. It should be taken in the evening, so later in the day. It can cause upper respiratory tract infections, pharyngitis, as well as sinusitis. There's Zeroflask Accolate. It's 20 milligrams twice a day, but that's if the patient is at least 12 years old. For people who are 5 to 11 years old, you can do 10 milligrams twice a day, but it's not really recommended if the patient's not at least 5 years old. It should be taken 1 hour before or 2 hours after a meal, so it's going to be taken on an empty stomach. It's known to increase liver function tests. It needs to be dispensed in the original container, so you don't want to be opening this up and putting it in a different vial whenever you are packaging the medication for the patients to pick up at your pharmacy. It is a substrate of 2C9 and 3A4, so you want to caution use with people who are also taking warfarin, theophylline, propranolol, and carvedilol. And the last one here is Xyluten Zyflow. It's 600 to 1,200 milligrams, 4 to twice a day. This should be taken within 1 hour of morning and 1 hour within the evening meal. It is not recommended for patients less than 12 years old. It is known to cause dizziness. It is a minor substrate of 2C9 and 3A4. So just like the Zeroflask, you want to caution use with warfarin, theophylline, carvedilol, and propranolol. So the main difference here between Zeroflask and the Zyflow: the Zyflow is not recommended for patients less than 12. The Zeroflask is. The Zeroflask is taken on an empty stomach, and the Zyflow is taken with meals. General precautions with all these leukotriene modifying agents: hepatic impairment, people who have depression, insomnia, or dream disorders, or Turg stratus, which is a syndrome where your blood vessels get inflamed. Some side effects include headache. You want to monitor LFTs and ALTs and monthly for the first 3 months, and then just once every 2 to 3 months for the first year. After the first year, you can just do it every so often. It's just periodically. It's just something you want to kind of watch their liver function. Next medication doesn't really fit into one of these classes, but it's theophylline, Theo. It inhibits PDE3, causing an increase in cyclic AMP, which is going to cause bronchodilation and smooth muscle relaxation. The dose is 300 to 600 milligrams daily. The peak level goal is 5 to 15 micrograms per milliliter whenever you're measuring the levels in the blood of theophylline. 1 milligram of ammophylline is 0.8 milligrams of theophylline. Theophylline is a little bit stronger than the ammophylline. It is a major substrate of 1A2 and 3A4. It can be used for treatment of lithium toxicity. General precautions, narrow therapeutic index, it does have that, so you really want to monitor those levels in patients. People who have high protein diets can decrease levels because it is kind of highly bound to protein, so it's going to decrease the levels. People who are allergic to corn, you might want to caution use. You want to avoid in dextrose containing solutions, so if you're going to do some sort of IV mixture, you don't want to put it in dextrose. Patients with congestive heart failure, hepatic impairment, hypothyroidism, or a seizure disorder, you also kind of want to avoid use in those patients. Side effects include headache, insomnia, restlessness, and tremor. You want to monitor, again, the peak drug level, their pulmonary function tests, their heart rate. Some examples of medications that can increase theophylline concentrations are zoflucas, Zaleton, ciprofloxacin, clarithromycin, erythromycin, amiodarone, propranolol, verapamil, estrogen-containing contraceptives, alcohol, allopurinol, methotrexate, and cimetidine. They can all increase theophylline concentrations. Examples that can decrease concentrations are carbazepine, phenytoin, rifampin, rifampicin, St. John wort, smoking, a high protein diet, or just in general other CYP3A4 inducers. We have roflumilast. It's a PDE4 inhibitor causing an increase in CAMP, bronchodilation, smooth muscle relaxation. So it's pretty similar to theophylline, but theophylline was targeting PDE3. This roflumilast is targeting PDE4. Dolorest is the brand name for it. It's 500 micrograms daily. It is a major substrate of 3A4 and a minor of 1A2. General precautions, you want to avoid patients with liver impairment, as well as carbazepine, phenytoin, phenobarbital, rifampin, St. John's worts, because they're 3A4 inducers, and that's going to decrease the concentration of roflumilast. Minor 1A2 substrate, caution use in patients with depression, suicidal ideation, and a past medical history of any psychiatric event. It could cause things like weight loss, headache, and insomnia. You want to monitor exacerbations of COPD, their general lung output, their LFTs, body weight, as well as questionnaire that they fill out whenever they're determining their COPD severity. So roflumilast, Delpress is more for COPD, FDA approved. Theophylline is used in asthma as well as COPD. This next class here we have is anticholinergics. They work by blocking the neurotransmitter acetylcholine from binding to receptors in the central and peripheral nervous system. So it's going to kind of prevent the parasympathetic nervous system from functioning, which is kind of controlling involuntary actions in the lungs, urinary tract, GI tract, and other areas of the body. There's going to be one medication, glycopyrrolate. It's kind of used pretty often to inhibit salivary glands and respiratory secretions. Bezpeace, it's formoterol, which is a long-acting beta-2 agonist, as well as glycopyrrolate. That's that anticholinergic component. It's 2 puffs twice a day. Utibron neo inhaler, indacterol, that long-acting beta-2, and glycopyrrolate, the anticholinergic. It's that capsule inhalation that's done twice a day. And then we have glycopyrrolate all by itself. Brie, it is also a capsule formulation that's done twice a day. Some side effects you might see with these anticholinergics include dry mouth, constipation, urinary retention. Your pupils could get dilated. It kind of reduces sweating. You could get anxiety or cognitive impairment. maybe even some tachycardia, sometimes arrhythmias, but not super frequently. So most of these anticholinergics are going to be used for COPD. Now we have some short-acting muscarinic antagonists. They work by binding to the M3 receptor and blocking acetylcholine, causing a decrease in cGMP, resulting in bronchodilation. These really are mainly used for COPD. Remember, because it's more of like a structural issue, where asthma was more of an inflammation issue. So we have ipratropium atrovent. It's 2 puffs 4 times a day as needed, with a max of 12 puffs a day. We got Combivent, which is a mixture of ipratropium and albuterol, which was a short-acting beta-2 agonist. You got 1 puff 4 times a day as needed or scheduled, with a max of 6 puffs a day. General precautions with these short-acting muscarinics: they're only to be used for acute bronchospasms, and you want to caution use in patients with a bladder neck obstruction, glaucoma, urinary retention, if they have myasthenia gravis, as well as benign prostatic hyperplasia. You want to kind of caution use because it can kind of aggravate those symptoms that you see in patients who have those types of issues. Side effects include abnormal bitter taste, respiratory tract infections, as well as a cough. You want to monitor their symptom frequency, like how frequent they have their COPD symptoms, their pulmonary function test. You want to do an annual spirometry on them, as well as the little questionnaire that they fill out whenever they're determining their category for COPD, as well as how many exacerbations they have. Then we have long-acting muscarinic antagonists. Just like the short-acting, they're going to bind to M3 receptors, blocking acetylcholine, causing a decrease in cGMP, resulting in that bronchodilation. So we have tiotropium spiriva, 2 puffs daily. It actually does come in a capsule form as well. It's good for 3 months after you open it. It is known to cause dry mouth. We got Stilito, tiotropium, and aldaterol. Aldaterol was that long-acting beta-2 agonist. You got 2 puffs daily, good for 3 months after you open it. It is also known to cause dry mouth. Aclinium tuzorza, it's 1 puff twice a day, good for 6 weeks, 45 days after you open it. Imiclidine and Cruz is 1 puff daily. And then we have Anoro, imiclidine with vilanterol, that long-acting beta-2 agonist component, is 1 puff daily. General precautions with all these long-acting: again, you want to caution use in patients with bladder neck obstruction, glaucoma, urinary retention, myasthenia gravis, and BPH. Some side effects include abnormal taste, respiratory tract infections, and cough. And just like with the short-acting, you want to monitor their symptoms, their pulmonary function test, as well as their questionnaire and their exacerbation. Some other COPD options is antitrypsin replacement. It's an IV infusion of alpha-1 protease inhibitors. It's going to lower your neutrophil elast concentrations and prevent the breakdown of your alveolar walls in your lungs. Examples are Arlas, Prolastin, and Zimara. This treatment is really limited due to the cost. They're very pricey. The frequent weekly IV infusions that is needed, as well as the anaphylaxis that is seen in a lot of these patients that's not really widely used. There's also monoclonal antibodies that work by blocking interleukin-5 from binding to eosinophils. There's Bepolizumab. Nucella is a sub-Q auto-injector that can be administered by the patient, so that's pretty handy. Rezulpimab Cinquar is an IV infusion that's administered in a healthcare setting. And then you got Benrelzumab Fasenra. It also activates FCY R3A receptors that are found on neutral killer cells. It is given sub-Q, and it is used to treat severe eosinophilic asthma. There is another monoclonal antibody that works a little differently. It inhibits binding of IgE to mast cells and basophil surfaces, which is going to lower the mediators to the allergic response. Oleclumab, Xolair, it's dosed based on the IgE level as well as the patient's body weight. It's given sub-Q every 2 to 4 weeks to be administered in a healthcare setting. General precautions: full symptomatic improvement may take a while to achieve on these agents, so that's not really going to be something that you start the patient on and they're going to see improvement within, a few days. It's going to take a while. It needs a skin positive test to an allergen. Whenever you are doing Xolair especially, you need to make sure they have like a skin positive test for it. It's only for patients greater than 12 years old, this Xolair is. You want to avoid abrupt discontinuation of corticosteroid use whenever you're starting them on this, so you don't want them to just all of a sudden switch this agent and just solely stop, taking their corticosteroids. You kind of want to taper them off. General side effects include headache, injection site reaction, joint pain, sinusitis, otitis media, as well as unstable angina and a rash. You want to monitor their baseline IgE levels as well as their anaphylaxis if they're going to have some sort of reaction to it, infections, as well as their systemic eosinophilia. So whenever you're thinking about asthma, it's more of something that can be reversed. It kind of is seen in your younger patients, where COPD is seen more in elderly and it's more of a progressive issue. In all technicality, you can't really reverse COPD. It's more of a structural issue. So whenever you're picking components for these, you do want to look at the patient of how they're presenting, because if they're COPD, that doesn't mean they're only going to be getting muscarinics. They could also be getting these ICSs. Just depends on what they're presenting with. And that is all they had listed for asthma and COPD. Again, my name is Amber Gawana, and I wish you the absolute best of luck in all your studies.